everybody. Just want to basically go through some objectives and we'll get started. So essentially what I want to do is give everybody some understanding of why diabetes and diabetic foot health matters by offering you some statistics. And those statistics will be Canadian and Saskatchewan based. We're going to talk about the importance of blood glucose management in foot health, because it's an underlying cornerstone of ongoing management of feet. To discuss vascular changes that may occur over time, and to look at some of the possible structural and neuropathic changes that can also occur to the foot in individuals with long-term diabetes. We'll talk about immune system alterations that again can be a result of long-term diabetes, key components of diabetic foot ulcer management, and to recognize when surgery might be an option. So as you can imagine, this is a fairly involved conversation, and I'm hoping that you guys will all have questions so that we can engage in some conversation. So why does this topic matter? The Saskatchewan diabetes cost model estimates that currently in Saskatchewan, 75,000 people have been diagnosed with type 1 or type 2 diabetes. Those are 2010 stats. So those numbers have already gone up. At 7% of our Saskatchewan population. The other issue is that number is expected to increase by 36,000 over the next decade to 9.9% of the population of Saskatchewan. So diabetes does matter. It's going to impact on a great percentage of our population. So Saskatchewan statistics. The economic burden of diabetes in Saskatchewan is estimated to cost the government here $419 million in 2010. And that cost is expected to rise by 27% over the next decade to $532 million by 2020. 2020 isn't that far away. So a few more stats. When we look at Canada, a little broader, annually, the money spent on diabetes in Canada is about $10 billion. And the bigger issue that I see as a clinician is the average cost to manage one diabetic foot ulcer if evidence-based practice is not used is $9,000. So lower limb amputations are 11 times higher in persons with diabetes. So horrendous statistics, horrendous risk. So we really need to talk about what can we do to prevent them, because the most important piece is prevention. So the first thing I'm going to say is approximately 15% of all diabetics will develop a foot ulcer at some time during the course of their disease. The issue is that 85% of those individuals with will then go on to have a lower limb amputation. So the statistics are staggering when you look at amputation post-injury. So the biggest thing that we can do as health professionals is prevent the injury. So one of the things that I'd say up front, because the most overwhelming response and the most overwhelming success we will have is blood sugar management. Everything in diabetes is key to blood sugar management, and that's where we really need to focus a lot of our education. And we really need to find a dietitian to support what we're doing, because hyperglycemia alters the immune response, it changes the blood vasculature, it affects every part of that individual. So it's really important that we involve a dietitian early and really look at, because it supports the infection and the prevention and management of the individual with diabetes globally and holistically, and also actually supports good foot health. So good nutrition supports immune competence, healing, and decreases the risk of infection. So it's very, very important that we find a dietitian and get her involved as quickly as can. So I'm going to talk a little bit about potential changes. Now again, these don't happen to everybody. Again, it's about blood sugar management and changes. I've actually known a nurse, and I've worked with her for she's been nursing for over 30 years, who's been diabetic for 30 years, who has none of these issues, as far as I know, with her feet. I didn't see them all that long ago. So you can actually retain function really quite efficiently if you manage your blood sugars. So what can happen is over time you can develop something called diabetic distal symmetric polyneuropathy. So essentially what that means is distal, of course, is the furthest from the heart. So we're typically talking about the feet, right? Symmetric, bilateral, both sides. So, and what it does is it involves all peripheral nerves. So there are three particular types of nerves we're talking about, and those are sensory. And most clinicians recognize loss of protective sensation. We've talked about it, we've heard about it, we recognize that people with diabetes can have minimal sensation to their foot. That's the one that we're most understanding of. But there's also changes, and we're going to talk about, to the autonomic nervous system. So I want you to think about what maintains your blood pressure. So individuals that have orthostatic hypotension have autonomic nerve changes. So it's quite global. And then lastly, motor neuropathy. So not everybody's familiar with all those terms, but we're going to delve down into those and look at them. The acronym to remember that by is SAM, sensory autonomic motor. So when we look at sensory neuropathy, as I mentioned, we're looking at loss of protective sensation. And actually, one thing I'm going to tell you is that light touch may be retained. And that's an important thing to remember, because sometimes what happens is we're going to actually demonstrate monofilament testing in a minute, but if you don't use a monofilament appropriately and put the right force on it, that individual may actually feel that and not have sensation. So it's really important that we use appropriate technique. The other thing I was going to say, with people with sensory neuropathy lose the ability to differentiate warm and cold. So recognition that they're at risk in our climate is also very important. As a background, monofilament testing is something that should be routinely done in diabetic patients, because at admission, if you're bringing them on to help them, support them, give their own insulin, to do teaching initially, whatever that happens to be, it should be really important that we do that as part of that process, because we need a baseline. If you know what sensation they had when they came to you, because some people are diagnosed and have no sensation already, and if we know that, unfortunately then it becomes not a really good monitoring of change. But if someone comes with intact sensation, it's a huge learning opportunity if you routinely test them and you demonstrate that there are changes, because then maybe they'll kind of start to pay a little more attention to some of the things that they need to manage. So I'm going to actually ask for my volunteer to come up, and we're going to demonstrate. Okay. So when we do monofilament testing, it's really important that, first of all, the person be comfortable. Right? That makes perfect sense. So typically I would ask them to sit. They need their foot up where I can access it easily, nice and clean. And what we'll do is we'll explain a little bit about it. So I'll explain to the individual that we're going to just test your sensation, because I don't want them to be afraid. And that we're going to I'll give you a test. So we're going to put it on your arm first. And I'm going to actually do that a couple times so they can pan and see how much buckle there needs to be on the monofilament. Okay, so you need to actually have it bend. Does that make sense? She needs to know what that feels like, because I'm going to ask her to say yes if you feel that, and where do you feel it? Because if I'm touching her great toe with this and she says to me, I feel it on the lateral part of my foot, she's neuropathic, because she's not feeling it where I touched her. Does that make sense? We use 10 sites. Though I will tell you, the heel is typically quite insensate. So it's not necessarily something, you don't get too excited if they don't feel it through the heel. Some places actually don't even test heels. Don't test through callus. And a lot of people with diabetes will have callus. So if there's calloused area, I mean, it's not a good indicator, right? And of course, if they have any open areas, don't test that. So what you do is you ask her to close her eyes, relax, and when you go through this, I'm going to use my finger first to show you. You test the first, third, and fifth toe. You test first, third, and fifth metatarsal head, inside, outside of the foot, the heel, and the top. And one thing I'm going to say to you is don't do it in particular order. Because what happens if people have been tested before, sometimes what they'll do is they will do it by rote. So for example, I had a gentleman who was actually a dentist that I used to visit, who had a partial amputation. So I was testing the toes that still remained. And as I'm going through, his brother-in-law is behind me, and his brother-in-law is a doctor. And the doctor's standing back there, and I'm going 1, 2, 3, 4, 5, 6 in order. And he said to me, stop. He kept saying yes, because I had time. There was exact same amount of time all the time, and it followed a sequence, and he would just say yes at the appropriate moment. Didn't feel a darn thing. So do alter the rhythm, do alter the location, don't go in a specific order. So what we would do is we would go there. Cheryl, your eyes have to be closed. Okay, but where is it?
My toe.
Which toe?
Big toe.
Thank you.
Little toe.
Okay.
Ball of my foot.
Okay.
Ball of my foot. Middle toe.
Okay.
Lateral side of my foot.
Okay.
Middle of my foot.
Okay. We're not going to keep going because I'm not sure if you guys can hear what she's saying, but what we're doing is I'm asking for the correct response, and we would, and sometimes you have to, and you do it twice. If they don't say it once, go back and test them again because, maybe give them just a fair shot. The other thing is if you accidentally skim it, like if it skims like that, they will often feel that because remember I said they often light touch is retained. So if that happens, that's not valid. You need to go back and do it again. Okay? Thank you very much. Okay. Thanks, Cheryl. So that diabetic foot screen is really that inability to detect the pressure of a certain gram. It's a 10-gram monofilament that's used. And this happens to be a little disposable one that I received at a workshop. You can buy them through agencies like the Canadian Association of Wound Care. And it is important to do that. And they're usually good for 100 tests. So that's typically the life of a monofilament. So if you can get disposable ones. So if you went to this, for example, this is not sales pitch, but the CAWC, the Canadian Association of Wound Care, sells disposable ones. We purchased those and put them on our documentation at home care in Saskatoon when I was doing this in order to test every diabetic that came into under our care so that we had that baseline. And then there's a process, I believe, set up to routinely do that. So it is important that people be taught, health professionals be taught to do that correctly. But it also is important to recognize when someone's lost sensation because it increases their risk 7-fold of ulceration. So then we have to do a lot more teaching and a lot more preparation. And then of course, again, ulceration risk goes higher yet if the foot has bony deformities or if there's any signs of poor circulation. So we review all of that, of course, as part of that assessment. Sorry. I actually talked about that, pardon me. Autonomic neuropathy is this A in SAM, and essentially what that does is it causes damage to the nerves of the heart and the lungs. I mentioned the blood pressure changes. It can cause things like shortness of breath with exercise. It changes your sweat glands, so you actually lose sweat glands, and what happens with that and the importance of that is your skin dries out when you stop having sweating as a lubrication for it. And then you end up with excess callus formations, which is called hyperkeratosis. So what happens is the foot will dry out. You've often seen those dry, cracked heels. Those are an open avenue for infection. So it's really important that diabetic individuals are taught to moisturize their skin. That's a key component of foot care, and not between the toes, because between the toes they can macerate. So we encourage them to lubricate the dorsum of their foot and the plantar surface of the foot without going between the toes, and that's a protection. Okay, that's very protective for them ongoing. Autonomic neuropathy can also cause calcification of arteries of the lower limb. And other things that can happen is it can change when in the capillary beds there are little tiny arterioles and venules that meet and exchange nutrients. They exchange oxygen and carbon dioxide in a grid at a very microscopic level. What occurs over time is diabetics have a tendency to have vasodilatory response and increased pressures in there. So what can happen, I don't know if any of you have seen this, is you can have someone with diabetes with a black toe and bounding pulses in their foot. And that's simply because there's of the destruction of vessels, and the two actually join together in larger and larger upside shunts. So it basically creates an AV shunt in the foot. And so often what happens is the circulation to the toes is severely diminished, but they still have circulation and bounding pulses to the foot. So it's very disconcerting because it seems like they have circulation, but sometimes that microcirculation is just not there. And so they really can lose that skin nutrition at that point. So motor neuropathy is a little different, and generally health professionals have seen this, and we don't always recognize when we first see it why it happens. So motor neuropathy affects the nerves controlling the motion of the foot, so how it moves. And so what occurs is you get a disproportionate shortening in one of the two. So there's intrinsic and extrinsic muscles in the foot. The intrinsic muscles will shorten or atrophy and pull up, and you'll get those cocked up toes, hammer toes, the hallus rigidus, where you get that really rigid great toe that pulls the foot out of proportion, and you get things like bunions. And it actually diminishes the strength in the forefoot of the diabetic individual. What that does is it actually causes balance issues. So if you have someone who's lost sensation, so now it's very hard to know, where am I? Where is my foot in space? Because I don't feel it. And you have that change in strength and musculature, it really actually causes a lot of balance issues. So there's a huge risk of falling. And I'm actually going to show you the difference, what you might see in the gait of somebody who's got diabetes. So when you and I walk, and when an occupational therapist does a gait assessment, what they're looking for is partially our ankle movement. So what happens is normally what you do is you heel strike, you put all your weight on your foot, and you push off with your other toe, right? And that's a normal gait. When you have diabetes, what happens is the tissues in your cartilage and your ankles and your muscles start to glycosylate, so they harden. And the ankle joint becomes quite rigid. So then and a loss of forefoot strength. So what they'd start to do is pound their foot into the floor. So when we talk about people with diabetes, and we're going to talk more as well about callus buildup. So if you're not distributing the pressure across the foot like that, and you're hammering that foot into the floor, those calluses cause a significant amount of damage. So that's really integral to understanding what happens. Okay. Whoop. So this is a very busy slide, and I apologize, but basically what it does is kind of tries to sum up some of what we talked about. So it talks about those microvascular changes, that dysfunction where you have loss of, and you actually can have a loss of inflammatory responses. You can well imagine if you have chronically vasodilation in the foot, how do you ever demonstrate any kind of an inflammation? Is it actually, so it's quite minimized, because it becomes a very chronic vasodilatation. And that AV shunting I mentioned, so what happens is because that exchange of nutrients and the Starling forces are no longer very functional, you actually shunt blood across and you lose a lot of skin nutrition. So what happens is if they get an issue or a wound in their foot, especially their toes, sometimes there's not sufficient nutrients to close that. The capillary basement membrane will thicken, and there is actually glycosylation of proteins, which I mentioned. So one of the things, though, that we can't forget is that when I did I did do a master's in wound healing, and what I did is I did my project actually on the effect of non-weight bearing exercise in diabetic foot ulcers, because you can't really ask people that have injuries to the plantar surface of their foot to walk on it, right? So we looked at the role of physiotherapist and doing some simple ankle exercises to improve blood flow and see if we could improve healing. And there was actually some very good physiotherapy-based research that looked at if you increase the movement in the ankle joint, so by simple exercises, and I just basically had use a pair of pantyhose, pull a foot up, push it away, do some inversion and eversion, and see if we could improve the movement. And you can actually reduce forefoot pressure by increasing ankle movement. When a lot of diabetic foot ulcers are on those metatarsal heads that I showed you behind the toes. So if we can reduce the pressure to that part of the foot, we can potentially increase healing, right? It makes perfect sense. So getting the physio involved early is also very, very important. They lose that eccrine gland function. Those are sweat glands. So they lose the function of their sweat glands and their feet dry out. So it is very important to have them look at their feet, to have them moisturize their foot, but to look at it as well. So I have to tell a story. I love to tell stories. And I used to have a gentleman in my home care, my little district, that I used to go visit every morning because he was blind, and I administered his insulin and I checked his blood sugars and his blood pressure and those things. And he was quite a character. And I'd been going to him for a little while, and finally I said to him, you know, I haven't looked at your feet. I didn't say, obviously you can't. I was nicer than that, but I said I really should. That would be a really good thing for me to do. And he said, you want to see my feet? And I said, yes, I do. And he took off his socks and shoes, and he had the feet of a baby. He had been clearly instructed, because he had no vision, he was completely blind, that he needed to keep his feet soft and moist because he couldn't see where there was any areas of damage, and he couldn't feel very much. So he told me, he said, what I do is I was told every time when I get in the shower, I sit down on the edge of the tub and I take a pumice stone and I pumice the bottom of my feet, I moisturize them, turn around, put my socks on so I don't go scooting across the bathroom, and off I go. And he had beautiful feet. So simply teaching people to actually it's not invasive to use a pumice stone, but to manage their feet and make it routine. And if you go for physiotherapy, the physiotherapist will tell you, you have to do an exercise over 1,000 times before it becomes routine. Because I'm actually having physio right now. And so they have to make it part of the routine. And he did, and it worked very well for him. So it's very important. Callus deformity, we'll talk more about that. But also what can happen is called a pev cavus foot, where the arch of the foot pulls up because of those muscles shortening as well. So they get a very, very high arch. And then the diminished sensation, and we talked about the fact that the toes change. So everything pulls up. So how can we, as nurses or health professionals, have an impact? We need to talk to people. We need to educate patients about the risk to their feet. We can't be afraid to have the conversation. Trust me, the internet's out there. They've probably heard somebody that's had a problem, but they need to know that it's preventable. And that's our biggest challenge. But we need to be clear on what those risks are, right? So that they can avoid them. So when I talked about those changes to the foot, you can only imagine how hard it is to get footwear to fit, right? So it's very, very important, especially if they start to have structural foot changes, that they actually get them fit professionally. And there is a couple of places here in town that do very well, but one of them in particular has podiatrists come in some Saturday mornings and actually evaluate some of their clientele. So have people check in their local backyard and see if there's a store that's particularly good about fitting shoes, and if they have any supportive resources for people. So shoes need to have a deep toe box. If those toes are cocking up, you need room for those toes so they're not rubbing, right? So they have to have a fairly deep toe box, and they need to be low heeled, because what you don't want is an angle because their foot will slide forward and it'll slam into the end of their shoe. And I actually had a lady one time, very elderly lady actually, that had diabetes, and I was trying to help her be very preventive. And I sent her actually to have shoes fit. And she came back, and I went to see her a few days later. And when I arrived back at her house, she had a black great toenail, which she did not have before. And I said, "What happened?" And she said, "Well, that's from those new shoes." Well, I was horrified, so I phoned up the people that fit her for the shoes and said, "These aren't working for her. You need to come out and reevaluate them and replace them." And they told me, "Oh, no, she has to come to us." And I said, "No, she's 80 plus years old, and it costs her a lot of money. You guys made the error. You need to come to her." And they did, and we got those shoes refit. But shoes can cause a lot of damage, and part of the reason, I think, was because there was probably too much elevation. Or the podiatrist has shown me how you can lace them. So if you get shoes that lace, you have the capacity to keep your foot in place better rather than something that's Velcro or elastic. Because what you can do is you can loop the top lace over and actually secure it really high and keep that foot in the proper place in the shoe. And a good shoe person will show you how to do that. You also need to suggest to people that they be fit late in the day. So I'm going to tell them, don't go in at 9 o'clock in the morning, because your feet aren't going to be swollen then, right? You want their feet at their largest point. So tell them, go in at 2 or 3 in the afternoon when you've been up and about and your feet are a little more swollen, because you want them to fit you comfortably. The biggest issue people have is inappropriate footwear. So if you see ulcers on the bottom or the plantar surface of someone's foot, it's probably because of callus, and we're going to talk more about that. But if there is ulcers on the non-weight-bearing surfaces, so the top of the foot, the top of the toes, the end of the toes, the dorsum of the foot, they're probably very much likely to be associated with footwear. So I do tell my stories again. So I had a gentleman at one point in my caseload who was a very large gentleman, and the nurses asked me to go out because he had a very superficial injury on the inner aspect of a foot, almost between his ankle bone and the sole of his foot. And they said to me, "It's a very strange location," and they couldn't figure out what was causing it. So I went out to see him. He was quite a character. And first of all, he didn't wear any shoes or socks in his shoes, which there's a potential for problems there, right? Because he has a draining area. It's not deep, but it drains. And I thought, oh, okay. So then actually, it was kind of disgusting, but I put on a pair of gloves and I put my hand inside his shoe. And on the shoe where he had that wound, what had happened is somehow he'd scraped it on something, whatever started it, and it's draining. And what happens is that drainage is hardened, and now it's like running your fingers along a cheese grater. It's taking his skin off every time he puts that shoe on. So, hey, put on a pair of socks. That alone in those circumstances could make a big difference. I mean, best thing would be to replace the shoes, but yeah, just putting on a pair of socks, because what's causing the injury is friction. Okay? If you see blisters, those are friction injuries. We've all probably had blisters in some point in our life from poor fitting shoes or too tight a shoe. So that's a really important consideration. That's a friction injury. And I mentioned to you that people lose sensation, right? So what happens if your foot starts going, for lack of a better term, dead, where you stop feeling it, sometimes what happens is people will put their foot into a tighter and tighter shoe so they can actually feel it. So, because that actually gives them a better sense of where their foot is. So one of the things we used to do is actually have someone stand on a piece of paper, and I'm no artist, but just trace their foot. You cut that out, and then you actually put it in their shoe, and when the paper comes up and folds up over the side, you can demonstrate to them how tight their shoe actually is. So it becomes a visual learning tool. So it's really important to evaluate footwear. Probably one of the most important things you do. And when you go to someone's house, or you go see them in the hospital, or you go and see them in the long-term care facility, are they wearing shoes? Because in the hospital, they should be bringing their shoes in and wearing them when they're ambulating for safety reasons, among other things. And you should be watching them walk when they're walking in front of you, because you can tell a lot by watching them walk. And one of the things I do is I actually consult for Health Canada nurses. And I went up to one of the Northern Reserves, and I see them, people in their offices. We have like a little clinic. And what occurred was this gentleman came in, and it was winter, and he had a pair of winter boots on. And I could tell as soon as I followed him into the room where that ulcer was going to be, because he tipped to one side. His one foot tipped to the side. So yeah, all he had was a heel. That's all that was left of his foot. Someone had stuffed a winter boot with styrofoam and created a little space for his heel. But his heel wasn't, the pressure wasn't equalized. And as soon as you have only this much pressures go up exponentially anyway. And the angle of it, so basically what he was doing is he was walking on this much of his outer heel, just this very, very small area. So that's where the wound was. So in many, many instances, the reason you can't get a wound to close is because of footwear. Because people continue to wear the same shoes. So looking at resources and how you can look at changing that is really, really important. But educating your clients around that, if they have minimal income, that shoes cost money. But buy one pair of really good shoes and wear them all the time. They need to wear them in the house. They need to protect their feet all the time. Because if they step on something, they are not going to feel it. And one of the clients I met was a 42-year-old gentleman who came to Saskatoon from up north, where he'd been working in a lumber mill. And he had stepped on a sliver and whether he didn't realize it or didn't react to it, I'm not sure, but he walked on that sliver for 2 weeks, came down and ended up in hospital with a severely abscessed septic foot. The first time I saw him, he'd already had a partial amputation of the lateral aspect of the foot, and that whole area had turned to gray mush. I turned around and sent him right back to the hospital, called the vascular surgeon. He went in and had a below knee amputation. That gentleman had had no previous diagnosis of diabetes. That was when he was diagnosed. So it's really important also to do hemoglobin A1Cs on most of your clientele routinely, because there's lots of unknown diabetics out there. He had to have had diabetes for a really long time to be completely neuropathic. So sometimes, things come up, and we have to remember to give holistic assessments to people, to really offer them that global look before we start, especially as our clientele are getting older. So one of the things we talked about was wearing your shoes inside, but the other thing is pick your shoe up, have them pick them shoe up and shake it out. How many times do things fall into shoes? How many times can you get a little pebble in your shoe and not know it's there? And I learned this because many years ago, we had a podiatrist given in service at home care when I first started there. And he was giving it on diabetic foot ulcers. And he told us about his client that had gone golfing. And you think, sounds pretty good, he can go golfing. But what happened was this gentleman played 18 holes of golf, came home, or wherever, took his shoe off, and was full of blood. What had happened is he had walked the entire golf course and played 18 holes of golf with his grandson's dinky toy in his shoe. He had no sensation and did not feel it. So as a result of that story and conversation, I always say to people, just get in the habit of picking up your shoe and shaking it out before you put it on. Just easy peasy, something to do, really helpful to help people prevent those kinds of injuries. Okay, so I know you all came to hear about diabetic foot ulcers. I do give a lot of previous information because of the importance of prevention. So we're going to talk about them now, and we're going to talk about the fact that they are typically a result of both peripheral neuropathy, which we've talked about, and peripheral vascular disease. Because of microvascular changes, there is a high incidence compared to the rest of the population of peripheral vascular disease in diabetics. It's about 35%. So it's quite significant, and it's really important that we be aware of that, because as I said to you, they can appear to have good circulation, but it can be altered. And when we talked about that, you know, we're going to talk about infection down the road, but one of the things that happens when we talked about managing blood sugars is what occurs if you are hyperglycemic. If you ever seen a diabetic educator give the conversation with the blood tubes about the changes, blood gets thicker when we have high blood sugar. So when you think about the size of a toe capillary, how does blood actually navigate through there if it's hyperviscous? So that's why the other reason managing blood sugars is so important, because you can actually reduce risk of clotting if you manage your blood sugars as well. Okay, so nothing is done in isolation. Shouldn't be doing the monofilament testing in isolation. When I look at Cheryl's foot when she was up here, we should be testing her pulses. We should be assessing her for edema. We should actually have both of the feet on the chair to actually palpate and see, is one foot cooler than the other. You can have vascular changes that are more significant to one foot than another. I've had huge variations in ankle brachial pressure ankle brachial pressure indexes between limbs when there has been some kind of an obstruction in a limb. So they can be variable. Feel both your feet, you know, and palpate the pulses. But we really need to palpate. There is a 10% of our population that will not have a palpable dorsalis pedis pulse. That doesn't mean they don't have it, just means that you can't readily palpate it. So there are two other pulses behind the malleoli that you can then palpate to see what their blood flow is like. But it's so important, if you're going to expect somebody to close a wound, that you identify if they have circulation to the limb. Now, it seems really basic, but I can tell you, a lot of times when I get consults, people neglect to tell me if they have local pulses. And I have to go back and say, could you please let me know if you can feel a pulse in that foot? Capillary refill is really important. And any of you who worked, especially in orthopedics, if you put any kind of cast or constrictive type of device around a limb, we always try to check for caps refill. So the most important thing is get the foot up. If you leave the foot on the floor and you depress the end of it and blanch it to look for refill, gravity is a huge force and will fill that and will actually bring that color back very rapidly, even in someone that doesn't have great circulation. So it's important that the leg be elevated at least at hip height, and that we actually depress and blanch the end of those toes, and we look for capillary refill time. 3 seconds or less is brisk. Anything more than that, we're starting to get into trouble. Okay? Because as I said, we need to know what's happening with the toes. Okay? There are a lot of the home care nurses in the province will do ankle brachial pressure indices. To my knowledge, I don't know that they're being done in any other health sector. They are not always accurate in diabetics, I'm going to say that. And there will be people that say to you, well, really the only accurate measure is toe pressures. That may be, but I don't believe anything is helpful in isolation. When you go to the vascular lab, they do sequential pressures. So they do actually put a cuff on their thigh, they put it mid-calf, they put it on their ankle, mid-foot, and toe. So when you look at the assessment of circulation, it's really important to look at it correspondingly. So if you did an ankle brachial pressure index, you should also be doing pulse palpation. You should also be feeling the foot to ensure that it's warm. You should be doing capillary refill. And if you have the potential, you should be doing both ABPIs and toe pressures, because all of them are actually individually can alter depending on the operator of the equipment. Nothing is absolutely accurate in isolation, and we need a global assessment to ensure that we're accurate. And as I said at the bottom of that slide, look at both limbs and compare. when they start to lose sensation, that can be also an indication of arterial disease because nerves need blood flow, right? So by itself, that can also help you to see, if they're neuropathic, there may be blood flow alteration as well. So the wound assessment, it's so important that you identify and look at where it is. Now the particular picture I have there is, I think you can tell, is an amputation site of a great toe. Well, where is the wound? It's on the very end of that toe. So where is that person likely walking? Probably their foot is curling up and they're walking on their toes. Because what happens as you get those intrinsic muscles shortening, where's my weight? It's on the end of my toes, right? So that's why some of those wounds occur. So when you see their foot, when you're changing their dressing, there's no weight on it. And often you can't see those deformities and exactly how much they're changed. So it's really not a bad idea to get them to stand on their foot in a controlled setting and look at how their weight is distributed. Look at the cause, because diabetes isn't the cause. Often it's a minimization of blood flow. It's probably, it may be infection. It may be breakdown underneath a callus. It may be a number of things that cause that. So if it's a callus that's causing the problem, it's callus reduction we have to do in order to manage that wound. So you have to look at what happened. Did they drop something on their foot? It could be trauma. And is it the footwear? So cause is extremely important. We always should be measuring the size of the wound, looking at the base, because that's going to help to tell you whether or not it has some infection or any other things going on, or whether it needs to be debrided, and the margins. So sometimes what happens, especially in diabetic foot ulcers, is those margins will callus, okay? Callus is a response to pressure. So if there's callus around the edges of the wound, it's because somehow there's pressure on that area, typically. So we need to figure out what's going on. And we need to minimize the callus buildup, because calluses are like rocks. And they walk on them and it causes all kinds of underlying tissue damage. I will tell you this wound, because you can tell it has depth. We need to take a Q-tip and actually introduce it there and see how deep that wound is. Okay, and that's simply because if there is a lot of infection in there and we actually put a Q-tip in there, and you can, trust me, you can feel bone with a Q-tip, but if you touch bone, there's about a 95% that's osteomyelitis, and that has been proven in research. So it's greatly important that we actually try to identify if there is bone that's accessible or easily poked. We're not poking around in there, but we just gently go in, and if you touch bone or if you see bone, really, really high risk of osteo. So what are the goals of treatment in diabetic foot ulcers? It's callus debridement. As I said, calluses are like stones. So when somebody has callus on the plantar surface of their foot, often behind in those met heads where I showed you behind the toes, they're walking on that. And I showed you how they slam their foot into the floor. So they're pounding that callus. If any of you have had a corn or a callus, when you feel how painful it is, they can't feel it. So what happens is that hard skin actually digs into their foot. And if we don't get rid of the callus, pardon me, it actually creates the ulcer. So people will say, oh, well, they'll say to me, well, that nurse actually, I think she caused my ulcer, or the podiatrist, because they filed that callus down and then there was a hole underneath. They should have left it alone. No, because that hole would be there irregardless. Some of you may have seen a large callus, and then what they do is they turn brown. They'll turn brown. That brown is bleeding underneath that callus. Until you remove that and expose the area of injury, you're never going to close it. It's just going to get bigger and bigger and bigger. So we need to get rid of that callus. We need to identify with our clients and teach them the fact that that ulcer was there all along and was not something that we could manage until we could see it. Because what happens is the damage just continues to occur. So callus debridement, and we're going to talk about podiatry involvement, is huge in diabetic foot ulcer management and pressure management. We're going to talk a little bit more about the details of that, but you saw what that foot was doing. You have to somehow try to distribute pressure across whatever foot surface they still have. We're going to go over some of the more appropriate features of wound management, but I mean that is a keystone, a cornerstone of treatment. Big one, recognition and management of infection. Many of the reasons people lose their limb is unrecognized infection. Infection is often harder to detect in diabetics because of an altered immune response. So we're going to talk about that. Early recognition of ischemic changes and referral to vascular surgery. There is tons of things that they can do. There's so much more research and new procedures that are being done that we need to recognize when someone has arterial changes, and they want to see them early. They don't want to see them late. They want to see them early when they can do something. We really need, diabetes doesn't typically occur in isolation. Individuals with diabetes have a greater incidence of peripheral vascular disease, and if you have an instance of peripheral vascular disease is systemic. So you're much more likely to have heart failure, high blood pressure, and all of those other cardiovascular changes. The management of those comorbidities is imperative to that holistic approach to care and the ongoing health of that individual. And then lastly, we're going to look at the last goal is surgical management. So a lot of times nurses don't feel, I think sometimes, that they debride, but actually a lot of us do, and debridement can happen with dressings. So the first type of debridement that's on that list is autolytic. And so if any of you have ever put, for the lack of a better term, a duoderm, a Comfeel, an occlusive hydrocolloid dressing over a wound, what happens underneath that dressing is it collects what they're called collagenases. Collagenases are in wound fluid, and what they are is they actually are enzymatic debriders that we have within us. And so underneath that dressing, it will get moist. Those collagenases will activate, and they will eat tissue. And usually if there's some dead tissue that's readily available, they will actually debride that or remove that. The trick with that is they're non-selective, so they'll also really cause a lot of damage sometimes in surrounding tissue. I'm going to tell you, autolytic debridement is not a good form of debridement in diabetics. Main reason is because they actually don't have a good immune system. We talked about that. It isn't very effective to put on something like a duoderm because they actually don't have very good phagocytic action. So the macrophages and neutrophils are reduced in diabetes. So that means that they actually do not clean up very well on their own, and that retained fluid actually causes risk of maceration. And I do not use hydrocolloids in diabetics because they actually get very macerated quite quickly, so that skin around turns white and pruny. And wet skin is a tremendous medium for infection. Bacteria love moist skin. And in fact, there was a research trial, a very small trial, done, and it was done on healthy medical students. And what they did is they took, 25-year-old medical students, and they took a wet cloth and they wrapped it around their arm, and then they covered that with saran wrap, and they left it for, about 3 days. And almost every one of them cultured positive for Pseudomonas on intact skin within 2 to 3 days of the application of that moisture. So on its own, wet skin grows bugs, because what happens is wet skin, the maceration, when it gets too wet, is it changes the pH of your skin. Our skin has a protective acid mantle. We actually have a fairly acidic mantle that protects us and minimizes bacterial growth on our skin. When it gets too wet, it actually becomes more alkaline. And so now we have exposure, just by nature of living, to all kinds of bacteria that have the potential to take advantage of that. So it's really important that we be careful of too much moisture because it's our biggest enemy in diabetic foot ulcers, in any ulcer, but especially in these. The preferable one is enzymatic debridement, actually, and Santal, Santal has actually just come back on the market. It was taken off the market, and it is a collagenase. And it's not being used very often, but there is a doctor that has a diabetic foot ulcer in Hamilton, Ontario that's using it with great effect. And it works very well. It's actually, as I said, it's a collagenase. The trick with Santal is it's a little bit slow to get that tissue cleaned up, and you cannot use silver, zinc, or iodine with it because they will interfere with its action. Okay? Mechanical debridement is essentially, sometimes we create mechanical debridement by how we clean things. So it's very important that we cleanse by using those dual top salines that have the twist off top, held 3 to 4 inches away. That has been proven in research to be the right pounds per square inch of pressure for appropriate wound cleansing. Do not use little pink 15 mil minims. The pressures are very high. Do not take people's feet out, uncover them with the dressing, take the dressing off, and put them in a high force shower. Those are things that actually cause mechanical debridement and tissue damage. The other way we create mechanical debridement is by using wet to dry dressings, where we actually put a moist gauze on and rip it off. And that's mechanical debridement. And hopefully, most nurses don't do that because we actually soak things off. But you will occasionally see people do that. And that is what mechanical debridement is. It's non-selective, it's very traumatizing to the wound, and it's really not a good way of doing business. The best way to debride diabetic foot ulcers is surgically. So it's evidence-based, it's selective, it's rapid, but of course it needs to be done by a physician or an advanced practice nurse in an appropriate environment. So it's not readily available. But necrotic tissue in a wound increases the risk of local infection and in the presence of adequate circulation. So they have to have blood flow. It should be sharply debrided in order to manage bacterial load and progress the wound to healing. And recognizing that a wound can actually increase in size during the debridement process. So again, that's a big teaching moment. We have to tell that client that your wound may seem to be getting bigger, but we're actually going to go forward because we've actually cleaned up anything in there that's actually splinting the wound open and preventing it from closing, and we're also reducing your risk of infection. So very important teaching points. So I did touch on the podiatrist slightly. Podiatrists are expert at callus debridement. They're expert at feet. And they are the ones that will help you to figure out how to pressure manage that foot. They can use things like deflective padding. They can get prescription insoles into shoes, prescription footwear. They are our best friend. They're an integral part of the treatment team. And unfortunately, not every health region in this province has podiatry access, but it's a very, very important thing to consider, and somebody that you really need to try to figure out how you can support that within your clientele, how you can encourage them to routinely have podiatrists do callus removal, because that in itself can help to really close wounds. And my last story, before we go to break, is about a gentleman that I had in community several years ago, who again, unrecognized diabetic, stepped on a nail in a garage when he was cleaning up, ended up with a hugely abscessed foot. It blew up like a balloon. And they actually did a fasciotomy. They split the bottom of his foot, and he came home on antibiotics, and I looked after him. Foot came in really well. He was learning about his diabetes because he'd never been diagnosed. And what happened is it came down to a very small area, very small, very narrow area, but it had a lot of callus around it. And callus actually splints wounds open. So what I said to him, sir, you really need to go and see a podiatrist. It's going to cost you about $60, but we really need to do that in order for this wound to progress. And he was really angry. He said to me, you promised me that this would be closed in whatever, 6 weeks or something. I said, no, I didn't. I said, I can't promise that because I can't promise you're going to manage your blood sugar, that you're going to take your antibiotics appropriately, that you're going to wear your shoes as you've been asked. But I'll promise you one thing, if you don't go and see that podiatrist and get that callus debrided, your wound will not close. He went. I made the appointment. He went. The callus got cleaned up and the wound closed within the next 2 weeks. So recognition of what that callus is doing is so important because it minimizes the oxygen to the wound, because that is that hyperkeratotic tissue in diabetes does not have any blood flow. And all it's doing is splinting that wound open. So if nothing else, if you get nothing else from this, callus debridement is key to going forward.
So, Donna, we do have some questions for you.
Okay.
First off, going back to with a monofilament, with a vibratip, can you use a vibratip to test sensation instead of a monofilament?
There is a vibrating, like a tuning fork. I'm not sure what they're talking. The vibration I know of is a tuning fork, and absolutely podiatrists do use that. We didn't have access to that as home care nurses. I would suggest that yes, vibration would help, but I'm not familiar with that.
Okay. What's the force on the filament to use? Are you just having it slightly bend, or is there?
Actually, if you pan on me, I can do it again. Sorry, give these guys a chance. So what you want to do is you want this monofilament to buckle.
So that's about like a centimeter of a little belly there.
Yeah. So I'll let them come right close. So you basically put it on the skin and you push down so that it buckles.
Okay.
I hope you guys can see that okay. I'll do it one more time. Okay.
Thank you. And then how many people are you testing with a monofilament again?
They're individuals. That's a very good point. It's single use. So that was one of the reasons we bought disposables, because they come in a little, I guess a cardboard case, for lack of a better term, that has actually some information on the testing process. And this was just one particular site. I should mention that there is free monofilaments in a small portion through the lower extremity amputation prevention site, LEAP, through the US. They'll actually send, I think it's a package of 15 they used to send free. I'm not sure they still do that. And then you actually use single use. So you could leave it with the client, or in our case, we left it on the chart so that we used it on the same person. Absolutely great question. Yeah, infection control issues there. Thank you. Or they can purchase one and you can use it on them, but it would be only one person, yes.
Okay, and we have a phone call from Anna from the Saskatoon Health Region.
Oh, hello Anna.
Hi.
Or they can purchase one and you can use it on them, but it would be only one person, yes.
Okay. Then we have a phone call from Anna from the Saskatoon Health Region.
Oh, hello Anna.
Hi, how are you?
Or they can purchase one and you can use it on them.
Hello?
Good morning. Sorry Anna, hi.
That's okay. Hi, I have a question regarding... Oh, sorry, it's hard when it's on the thing there. Okay, we have a client who's been coming for the last over 2 years with ulcer to the 5th metatarsal head. It's dropped, and he sees podiatrist monthly, and they shave off the callus, and he sees ortho, I think every 6 weeks, because he's had osteomyelitis a couple times. He's got an offloading boot now. I talked him into having that assessed, but we still can't close that wound. And I'm wondering if you have any other suggestions or places that I could refer him to.
Okay. So when you say an offloading boot, are you talking an offloading cast boot?
No. So I did ask him to look into the total offloading cast. And they told him that he would have to come to Saskatoon 3 times a week, and he couldn't afford that because we live in rural here, and that it would be $100 a change.
Okay.
So it's just a little, actually like felt shoe that he puts on. They called it an offloading shoe.
Oh, okay. When I'm thinking of a cast boot, I'm thinking of an air cast. Lots of times they purchase an air cast and they actually wear that.
Okay.
And that might be what he needs, because if there's no infection, which is he on, what are you using any kind of antimicrobials or any kind of antibiotics?
It's been Acticoat Flex.
Okay.
He comes in 3 times a week for the dressing change, and we put the Acticoat on. And he isn't taking any antibiotics now. He finished it just a couple months ago for
Okay.
another round of osteomyelitis.
Okay, so how long have you been using the Acticoat Flex?
Oh, like 2 years, like way too long.
Yeah, I think that is way too long. Now, the
Yeah.
silver might be the problem.
Okay.
Honestly, I think that if there's no signs and symptoms of infection, I would, pull that back and monitor that and just see if that makes a difference, because the more layers you put on, potentially the more pressure that he's walking on. The other thing I would do is look at I know that it's almost impossible for people, but what they need to be wearing is that offloading device 24 hours, other than when they're in bed.
Yeah, I told him that. And actually, at first he wouldn't wear it because it threw his balance off even more. And now
Yeah.
he actually got himself 2 of these boots, one for outside and one for in the house.
Okay,
And
well,
because he's seen how much his ulcer has reduced since he's been wearing it, the compliance is actually pretty good. But
Good.
obviously there's still pressure because we can't
yeah,
close the wound.
that's a really tough area to heal. Has the podiatrist, did he prescribe, she prescribed the boot?
No, actually it came through from the orthopedics. Like, that's the other thing. He's paying out of pocket every month
Yeah.
to see this podiatrist, and I'm like, I think we need another opinion.
Is the podiatrist local? I'm sorry, these are all the questions I'm trying to figure out, though.
Yes,
Okay,
it's
so
a traveling podiatrist that goes to the smaller communities.
So he wears the boot when he goes to podiatrist.
Yep.
So the podiatrist could assess the boot, which I think is the first step in this, and ensure they should be able to tell whether or not the pressure's offloaded efficiently in that boot that he's got, or whether you need to look at a different option. And sometimes they can put a little bit of deflective padding, depending on the space, that might just be the last bit that you need. I think I would actually interface with that person and see how they feel about that, and to see what their comfort level is. And the other option is to get a different podiatry opinion depending on how that goes.
Yeah.
And that might, and if you, Anna, you can get a hold of me through CEDN if you need a suggestion for that.
Yeah, that
How's
would be awesome, actually, because I was going to ask you, is there a way that we can get him into, I hear the podiatrist for the region is very good,
Okay.
or whomever, but yeah, I think he would look at a second opinion, because he has asked the podiatrist about offloading, and he hasn't gotten any further feedback about
Okay,
that.
then yeah, I would actually look, and if you like, actually phone back on the line and get Cheryl to either leave me, or get somebody to either give me your number, or
Sure.
and we can have a conversation about that off air. But the other thing is, has his circulation been tested?
You know, I'm not sure, because he doesn't doctor with us. He just comes to us for dressing changes.
Okay.
And so there's been no communication between the ortho or the podiatrist and us.
Okay.
We just get the dressing change orders.
Yeah, it's tough doing that in isolation. I would ask for a vascular surgery referral,
Okay.
if you can get him, unless you guys have toe pressure and ABPI access, which I'm guessing you don't.
We can do it. Home care
Okay.
can do it for us.
Okay, do they do toe pressures as well?
Not toe pressure, just the ABPI.
Okay. It might be, depending on, that might be the way to go, is to see about vascular surgery, because often you just need a little bit of extra blood flow to get closure, and sometimes that's the mountain you haven't climbed. So if you don't get anywhere with the podiatry change, the next step might be to see if there's any circulatory issues. But I would change up the dressing regime and try to limit the number of layers and monitor it closely.
Okay, great.
Okay?
Thank you.
Thank you for calling.
You bet.
Thanks,
Bye.
Anna. All right, so some more questions. Do you recommend a pumice stones? Something about metal? Would people use metal on their feet? Or like, what are we doing here?
No, I would suggest a pumice stone, or one of those, you can get the flat paddles.
Yep.
That you can rub with. No, nothing metal, nothing sharp. Remember, if you tear the skin, that creates an opening, and pumice stone is very non-invasive. It has to also be right after they come out of the shower or the tub, whatever it is, because when the skin is a little bit moist, it's easier to just take a very little bit of skin off. It's just doing it routinely. And really, you're not taking a lot of skin off. You're just doing it like you or I would do it. Does that make sense? So it's not invasive. It's not deep. It's just routine.
Okay. And then what about the level of mechanical debriding that registered nurse can do versus podiatrist or wound care nurse?
Mechanical debridement is basically, as I said, wet to dry dressings. So
Okay.
it's basically tearing gauze off of wounds. It's not anything that we should routinely be doing. There's no mechanical debridement is not a good option. I mean, and that's what happens often by mistake because we put them in a shower that's too high a pressure. If you're using the saline to cleanse properly, it doesn't debride. So if there's no, I guess there's no really good reason to me to use mechanical debridement. It's either, is there an enzymatic option, or can we get them somewhere like podiatry for sharp debridement?
Okay, and can you just go over the enzymatic debridement?
Enzymatic, the one I mentioned was Santal. But there are a couple of other products that can help to lift things like slough. So slough is that yellow stringy material that ends up in a wound. And if you have that in there, Iodosorb is one product. It's an iodine based, but it's not betadine. It's very different. It's Codex or iodine. It will actually remove slough, and fairly rapidly. But again, you have to be sure that they have blood flow to support healing. And that is another one that can actually help quite a bit.
So Santal,
it's
S-A-N-T-I-L?
T-Y-L.
T-Y-L, thank you.
Thank you. And it would be prescription, I believe.
Okay. We still have a couple more minutes here. I have another question about, can you clarify bunions and hammer toes, hereditary or secondary cause from diabetes?
In this instance, typically secondary cause. That does not mean that people won't have bunions that don't have diabetes. There is a genetic influence, but the changes that can occur from neuropathy can actually create bunions, and especially hammer toes. Though that pulling up of the toes is very, very common in diabetics. And like I said, until they put their weight on, you may not see how much their toes pull in. So that's why I say get them standing without their shoe on and take a look, because honestly, the entire structure of their foot changes on weight bearing.
Okay, thanks, Donna.
Okay, thank you.